Good evening and warm welcome to all the viewers. I am Rupesh Salve along with Dr. Mangesh Bhalerao, HOD RPG Life Sciences, and on behalf of RPG Life Sciences and Delhi Liver Foundations, cordially invite you for a webinar on a topic steroid refractory ulcerative colitis. What's next? To talk more on this, we have with us panel of doctor to conduct this webinar. We have Dr. Professor SP Mishra, Dr. Professor R. Kochar as the moderator. He will conduct today's whole sessions. Before that, I would like to introduce today's our guest and moderator. And after your introductions, I request you decide among yourselves and please introduce our today's guest speaker. Dr. Professor SP Mishra is a gastroenterologist and hepatologist currently working with Motilal Nehru Medical College Department of Gastroenterology and Hepatology. And our second moderator is also a renowned gastroenterologist, Dr. Professor R. Kochar, is currently associated with Postgraduate Institute of Medical Education and Research, Chandigarh. Welcome, sir, and thank you for joining us. So, without any further delay, I welcome Dr. Professor S.P. Mishra and Dr. Professor R. Kochar, sir, and would request you to continue the session. Thank you, sir. Over to you.
Okay, thank you. Well, this is an interesting program. We all come across this problem of acute severe ulcerative colitis. Steroids are given quite often. And what happens when we have steroid refractory ulcerative colitis? That is the theme of today's meeting. And we'll have 3 talks on this, 20 minutes each, followed by panel discussion. And hopefully we should have a lot of questions on this topic to each of the 3 speakers and thrashing out some of the issues which we face on day-to-day basis. It is something which concerns all of us. And the first speaker for today is Professor Anil Arora, who is chairman of the Department of Gastroenterology, or rather it is the Institute of Gastroenterology, Hepatology and Advanced Endoscopy at Sir Gangaram Hospital, New Delhi. Dr. Arora is a multifaceted person and he does full justice to the job he takes up. And today he'll be talking on pathobiology, definition and causes in the context of steroid refractory ulcerative colitis. Dr. Arora, please.
Thank you, Professor Kochar, for an elaborate introduction. The topic of my talk today is pathobiology of refractory ulcerative colitis. Greetings from Sir Gangaram Hospital, where I've been working as a consultant. So my talk is going to be on pathobiology of ulcerative colitis, especially in reference to the steroid resistance. How do we define the steroid resistance and steroid dependence in patients with ulcerative colitis? Why do patients with ulcerative colitis ultimately end up with glucocorticoid resistance? What is the role of infection in patients who are resistant to steroids in ulcerative colitis? What do our international guidelines tell us when we talk of ulcerative colitis, which is refractory to steroids, and a few lines about the carry-home message. Starting with the pathobiology. May I just first present to you the basic of immunology of the gut. Now, human gut is one of the biggest organs in the body. And as we swallow and ingest a lot of food material, with every incoming food, you are swallowing millions of bacteria. And fortunately for us, majority of these bacteria, they tend to get degraded in the harsh acidic environment of the stomach. But certainly, as happens, some of these hardy ones do tend to cross the stomach and land up into the small intestine, whereas God has given us this beautiful structure called small intestine, which is covered up with cobbled microvilli, which gives you extensive surface for absorption of the food. But interspersed amongst these villi are these dome-like structures called Pierce patches. This is the crux where the immune system starts. So this is a typical Pierce patch in which what happens is these are the lacteals which will bring the food down into the lamina propria and into the vessel, and all the lymphatics and the antigens both from the Pierce patches will go to the mesenteric lymph node and subsequently go to the lymph node. You have lamina propria, you have crypt at the base of the villi which will try to give you regeneration. So a defense consists of an epithelium and its covering mucosa. If you look at the detail of this covering mucosa, so this is the epithelium, this is the gut lumen, which is teeming up with millions of bacilli. Then in the lamina propria, you have these dendritic cells, you have these macrophages, which are just roaming around in the upper part of the lamina propria. There is a special cell in the in the Pierce patches called M cells, which keeps on transferring the microbiome from the gut lumen into the lamina propria. And once this dendritic cells gets activated by these food material and the commensal organisms, it tends to put in a lot of dendritic cells out into the gut lumen, which keeps on capturing the antigens. So these dendritic cells and macrophages, they keep on capturing this normal food antigen and the commensal bacteria and go down into the deeper part of the Pierce patches, where they activate the naive T cells and produce something called Treg cells. Now, these T regulatory cells are extremely important. They will produce pro and non-inflammatory, anti-inflammatory cytokines, and these T cells, which are now called Treg cells, they go onto the upper layer of the lamina propria. They will secrete anti-inflammatory cytokines called IL-12. IL-12 will take care of all the inflammation and is a most potent anti-inflammatory substance known in the lamina propria. So you maintain the integrity of the gut, you maintain the integrity of the epithelium. But somewhere down the lane, either because of infection or because of the mechanical trauma or because of the chemical trauma, there is a disruption of the epithelium. Once there is a disruption of the epithelium, large amount of the bacteria and the other parasites, they move into the lamina propria. Now the IL-12 producing Treg cells get exhausted, and these dendritic cells are again putting in dendritic components out into the lumen to capture more antigen. Mind you, as the dendritic cell is getting more and more antigen, it is not able to distinguish between a foreign and the native antigen and produces pro-inflammatory substances called IL-6, IL-12, which will now produce effector T cells as against Treg cells. And once you have effector T cells, then you will have culmination of TNF alpha, interleukin 6, interleukin 12, and all inflammatory cytokines. Once these land up in the lamina propria, that leads to pulling up of the neutrophils from the vascular system. These neutrophils, they tend to coalesce with each other and then they produce an extracellular matrix, which will try to now gobble up all the mess which had been created by the incoming bacteria. So all the abnormal T cells, leukocytes, dendritic cells ultimately are eaten away by the macrophages, dendritic cells, by this extracellular mesh prepared by the neutrophils. So once there is an acute injury, there is a mechanism to take care of this by this mechanism of anti-inflammatory cells. Finally, there is a reconstitution of epithelium and patient gets back to normal self. But what happens in patient with ulcerative colitis? So it is not a one-time event. The number of environmental factors, autoimmune patterns, genetics, and the altered gut microbiomes, they keep on altering the mucosal immunity of the gut, leading to the repeated inflammation and infection. Let me show you how it does it. Typically, what happens in ulcerative colitis is that in patients with ulcerative colitis, you have less diversity of the microbiome within the gut. So there are small number of short chain fatty acids. That leads to decreased production of the mucin. So this is the second component of problem in ulcerative colitis. So in presence of decreased short chain fatty acid and decreased mucin, there is a disruption of the epithelial barrier that leads to the breach of the mucosa and transmigration of the bacterial antigen into the lamina propria. So once these antigen get exposed to antigen presenting cell, there is an activation of the neutrophils which come over here from the vascular endothelial system, which I'll show you quickly. So again, neutrophils will try their best to produce an extracellular trap and try to get rid of it. But because of some genetic factor or because of the repeated infection, now you're having transmigration of the cells from the immune system, from the blood out into the lamina propria of the gut. So you have T cells which are coming out, you have neutrophils which are coming out, and once you have Th1 cells, they produce pro-inflammatory cytokines which will keep on perpetuating the inflammation. Another thing which happens in patients with ulcerative colitis is they produce the epithelial cells produce a typical interleukin called IL-36, which has a tendency to suppress T regulatory cells. So the anti-inflammatory cells are getting suppressed, pro-inflammatory cells are getting activated. And finally, you have this substance called NK cells, which has a tendency to disrupt the epithelium. So multiple things are happening. You are having breach of the mucosa, you have suppression of the anti-inflammatory cells, you have a constant bombarding of the epithelium cell and its junction to produce a persistent inflammation, which leads to disordered immune system in the gut. To summarize, the main abnormality driving inflammation in ulcerative colitis involves an exaggerated T cells response, which is called, earlier it was supposed to be altered Th2 response, but now it is called a modified atypical Th2 response, which causes mucosal hyperresponsiveness to so-called commensal bacterial organisms in a genetically predisposed host. That means if you are genetically predisposed, even do commensal bacteria, you will keep on mounting the response. How do these blood cells from the blood system, from the vascular system, come out into the circulation? I think this is an important video to understand. It shows that WBCs will keep on roaming around into the lumen of the gut. How do they know they have to go to the lamina propria of the gut? So for WBC to land up into the lamina propria, it has to get activated, it has to get adhered to the endothelial system, and by the process of diapedesis, it has to land up into the lamina propria to cause activation. So this all occurs because of a substance called interferon. I'm sure we'll be talking of it in therapy of ulcerative colitis very quickly. TNF alpha is an important molecule which all of us should understand at the basis. And then you need to have this molecule which is called integrin molecule for activation. Because of the stimulation by the gut microbiota or by interleukins, macrophages produce this substance called interferon alpha. So either by endotoxins or IL-6, you are producing interferon. You are producing TNF alpha. TNF alpha by this enzyme called TACE is split into TNF and its receptor onto the surface. This TNF goes into the circulation. And once this TNF lands up into the circulation, it attaches to the TNF receptor onto the vascular endothelium. The moment there is an activation of the TNF receptor onto the activated epithelium, there is an increased expression of these adhesion molecules, which are called VCAM or MADCAM, that is molecular adhesion molecule 1. So these, if you are able to take care of this interferon by blocking the action of the interferon while it is splitting into the interferon and its receptor, you're able to block this process so that there is no activation of the TNF alpha, and there will be no further stimulation of migration of the leukocytes into the lamina propria. Similarly, if you are able to block these receptors to which the leukocytes attach, that is VCAM or MADCAM1, you are able to prevent the diapedesis of the neutrophils into the lamina propria. So with this mechanism, you are able to prevent the inflammatory activity which occurs in patient with ulcerative colitis. Another mechanism which is important in causation of inflammation in these patients is this substance called JAK or Janus kinase. This is the important set of pro-inflammatory cytokines which are produced by the T cells. Now, this Janus kinase family has multiple cytokines called and intracytoplasmic receptor called JAK1, JAK2, JAK3, and tyrosine kinase TYK2. They have intracytoplasmic component and they have a extracytoplasmic component. The moment you try to stimulate them, you produce a lot of pro-inflammatory cytokines like IL-2, IL-4, IL-7, IL-9, IL-13, IL-15, IL-17, IL-23, and IL-21. So any stimulation of JAK1 and JAK3 will lead to development of inflammatory bowel disease. So if you're able to block this activation of the JAK pathways, which I'll explain you how this JAK produces a pro-inflammatory cytokine, you're able to get rid of the inflammation in patients who have steroid-resistant ascites, steroid-resistant ulcerative colitis. So in patients who have stimulation of the JAK, all JAK receptors have one common pathway, that is they stimulate the formation of the STAT pathways. So any ligand like cytokines, when it attaches to the JAK2 receptors, it stimulates and activates the JAK component of the activated receptor. There is a phosphorylation of the JAK, it becomes activated. Activation of the JAK leads to phosphorylation of the terminal end of this receptor, to which attaches the STAT component. STAT is also getting phosphorylated. Once it is phosphorylated, it will separate away from this complex, and the two molecules of the JAK, they combine together to form a dimer. And once this dimer is formed, it quickly moves to the nucleus and gets attached to the component of the DNA which encodes for the pro-inflammatory genes and pro-inflammatory cytokines. So once you have stimulation of the JAK system, you are producing a cascade of events which will produce pro-inflammatory cytokines. So if you're able to plug the stimulation of the JAK by inhibiting it at this level or at the level of its stimulation of the STAT pathways, you are going to do a human service by decreasing the inflammation. Similarly, if you give steroids to a patient, let's say what happens. If you give steroids to a patient, it will come and attach to the surface of the cell on which it has to act. Once it comes in, it attaches to a glucocorticoid binding protein and lands up in this complex called glucocorticoid receptor, which is typically inactivated by its attachment to HSP 70 and 90. Once glucose is attached, there is a phosphorylation of this molecule, and because of the activation, these inhibitory polypeptides are separated. Once you have an activated glucocorticoid receptor, it goes inside the nucleus and gets attached to a gene within the DNA, which is called glucocorticoid response element of the DNA. What it does is it produces two types of effect. First effect is it will upregulate lipocortin and it will downregulate the transcription of this COX-2. So by upregulation of the lipocortin and downregulation of the COX-2, it is going to cause decrease in the thromboxane A2 as well as in pro-inflammatory cytokines, which lead to suppression of the inflammation. So this is what happens. Once you have a glucose which is entering the cell, it will bind to the glucocorticoid receptor, and once this receptor is activated, it moves into the nucleus and it's in the form of two dimers. Once it enters the dimer, it stimulates a gene called IKB alpha gene and APC1 gene. And what it does is it causes movement of the TNF producing gene out into the cytoplasm. So the sheer activation of the glucocorticoid causes suppression of the TNF producing genes, so that you are not able to now move the corticoid into formation of the pro-inflammatory cytokines. So that is where the steroids are acting. Steroids are basically blocking the formation of the TNF-induced pro-inflammatory cytokines through suppression of the TNF activities. Overall, 1/4 of the patients with ulcerative colitis are steroid dependent, and 1/6 are the steroid resistant cases. So in your practice, if you see ulcerative colitis, almost every second patient will either be steroid dependent or steroid refractory. We say that the patient is steroid resistant when he is not able to have control of the disease in spite of giving 0.75 milligram per kg per day over a period of 4 weeks and still continue to have symptoms. Anybody is called steroid dependent if you are not able to taper down steroids to less than 10 milligram per day within 3 months, or if there is a quick relapse within 3 months of stopping the therapy, that is steroid dependent. What are the causes of this dependent? One cause is that there is a decreased cytoplasmic concentration of the glucocorticoid, or there is a problem in the signaling of the glucocorticoid, or there are other mechanisms or other infection which are causing steroid resistance. So these are three major reasons why patients become steroid resistant. One is that there is a activation of the gene called MDR, or multi-drug resistant gene. What it does is, as soon as steroid enters the cell where it is supposed to be effective, it causes extrusion of the corticosteroid. That is the first step as to why patient becomes steroid resistant. Second reason is there is an increased expression of the non-ligand binding glucocorticoid receptor. That means you will have other ligands which will bind glucocorticoid, and they'll not be able to go to the DNA to cause suppression of the TNF producing genes. And finally, you may have activation of the other mechanisms, like you can have P50, P68, P38, P65, P50, which may be causing exacerbation of the pro-inflammatory cytokines in actions other than mediated through the anti-corticoid actions. So if you look at the literature, about 20 to 30% of the patient in different series have steroid resistance. There is data to show that about 15 to 16% of the patient with steroid resistance, the cause may be an underlying infection. This has been reported also from India, that 15% of the patient in one of the Indian studies had CMV as one of the causes of steroid resistance. There is also good relationship between Clostridium difficile infection and the IBD, and it has been shown that 6% of the patient with ulcerative colitis will have C. difficile infection. If you have C. difficile infection, your chance of having colectomy is about 3.39 times more, and 20% of the patient with IBD with the C. difficile infection ultimately may require colectomy. This is just a summation of the Indian data about the prevalence of infection in refractory ulcerative colitis in India. That Clostridium difficile toxin, this was reported by our moderator, Professor Kochard, that 32% of the patient with acute exacerbation of the disease, the cause was Clostridium difficile infection. Another publication from Janak Kishore's group that showed that 15.8% of the patient had CMV. Various other organisms like Entamoeba histolytica, strongyloidosis have also been implicated in exacerbation of the disease. And obviously all these will be steroid resistant. And various studies have shown, because of the different heterogeneous type of studies, that 20 to 30% of the patient may have CMV infection. This is the publication from Dr. Ajit Sood's group, which showed that of the 146 admissions of severe ulcerative colitis, about 16% were so-called steroid resistance. There's a relationship between the CMV and the steroid resistance, and typically it is known that CMV infection might be nearly 7 to 8 times higher in IBD patient than in control groups, thereby indicating a causal relationship between IBD and the CMV infection. CMV disease typically occurs in seropositive patient. It is almost always a reactivation in patients rather than a primary infection. In fact, latent CMV infection tends to occur in patients who are having a prolonged disease. A typical setting of ulcerative colitis in which you have a persistent inflammation, because CMV virus has a typical tropism for the inflammatory cells. So if you have a persistent inflammation along with large amount of immunosuppression, that is a classical setting when CMV infection will occur. Typically, diagnosis is made by demonstration of these owl-eyed cells, which are seen in this picture. Various other studies from the Western world have also shown that about 30 to 40% of the patients may have CMV as a cause of steroid-resistant ulcerative colitis. And in such patients, typically it will occur in those patients who are having a persistent inflammation, in which you may need to use a higher dose of steroid because of the lack of the response. The reason why we do not have good consistent data about the prevalence of CMV in different studies from the international community is because different authors have used different criteria for defining what is steroid resistance or dependency in various groups in different time frames of the series presentation. But the high prevalence of the CMV positivity in patients with IBD inconsistent definition of the severe and steroid refractory bursitis and different methods of CMV detection like antigen, IHC or CMV DNA, that is what makes the results totally desperate as we see today. So still we are not sure whether CMV is an innocent bystander or a causative organism for the disease. But if you look at all guidelines, what do they tell us? They do tell us before saying that the patient has steroid resistance or switching on to something which Dr. Shirihari and Vinita are going to talk about now, we must rule out all infections, including CMV, both in steroid dependent and steroid refractory ulcerative colitis. Same thing has been echoed by the British Society of Gastroenterology Clinic that CMV infection, C. difficile infection should certainly be looked for and treated adequately before you try to label a patient to be having steroid refractory ulcerative colitis. This is the 2020 guidelines from ACG, which has shown that significant proportion of the patient with acute severe ulcerative colitis, which we call steroid refractory, may have an underlying CMV as the cause of the disease. Unless that has been taken care of, we should not say that the patient has a steroid refractory ulcerative colitis. So to sum up, ladies and gentlemen, my take-home message is main abnormality driving inflammation in ulcerative colitis involves an exaggerated T cell response, which is now called modified atypical Th2 response, which causes mucosal hyperresponsiveness to commensal bacteria in genetically predisposed host. So everything is important. So it is an abnormal response to a normal commensal bacteria in a genetically predisposed host. About 40% of the patient with ulcerative colitis at some point of time will either become steroid dependent or refractory. Steroid resistance is said to occur in patients who do not respond to that much dose of steroid for a period of at least 4 weeks. And if you're not able to taper down to a level of prednisone to less than 10 milligram, or if there is a quick relapse within 3 months, that is the definition of steroids dependent. And the key factors for steroid resistance are the increased expression of MDR1 gene, which causes efflux of the glucocorticoid from the cytoplasm, impaired glucocorticoid signaling, and constitutive epithelial activation of the pro-inflammatory mediators, which bypass this pathway of activation. And certainly at all stages, we must rule out CMV infection as well as the other common bacterial infection which cause steroid resistance. Thank you so much. With that, I'll hand over it back to the moderators.
Thank you, Dr. Arora, for a very basic introduction to the pathogenesis of IBD, ulcerative colitis, and how steroid resistance develops. I think we'll go on to the next talk, and I'll request Dr. Mishra to introduce the second part.
Well, now we have a talk by Dr. Srihari Anikindi on infliximab, adalimumab, or cyclosporin, which one to be used. And this is an important talk, and this will be followed by Dr. Vineet telling us about the newer molecules. So Dr. Anikindi is a consultant at Sir Gangaram Hospital and the Institute of Gastroenterology there. You're on, sir.
Thank you, sir, for that kind introduction. So it is indeed an honor to be a part of this symposium involving such accomplished stalwarts in gastroenterology. The topic that has been allotted to me is to deliberate on 3 important drugs that are commonly used in steroid refractory ulcerative colitis, that is infliximab, adalimumab, or cyclosporin. In the next 20 minutes or so, I would try and give full justice to this topic and try to answer most of the common questions that we face in our day-to-day clinical practice, and also try to find definitive solutions as to which agent should be preferred over another in specific situations. So coming to the era before these drugs were introduced, that is the era of steroids. So we all agree that steroids in a way where it was a magic drug for treatment of ulcerative colitis. In the pre-steroid era, the mortality for acute severe ulcerative colitis was more than 75%, which was substantial. So in 1955, Trulov and Witz published their first control trial in which they used cortisone in ulcerative colitis, and this drastically reduced the mortality rates from 75% to 7%. So that was a superb achievement. Over the next 10 years, the mortality in ulcerative colitis remained the same. Gradually, surgeons started realizing that people who are not responding to steroids can undergo a colectomy, and the rates of colectomy started increasing. At the same time, the mortality from acute severe ulcerative colitis started declining. In 1974, Trulov and Jevel reported their experience, and they said that you have to go in for early surgery. So patients who underwent early surgery within 5 days, and patients who were refractory for steroid in acute severe ulcerative colitis, and then the mortality rate declined even further to 1%. So what we were able to achieve in such patients was a mortality rate of 1%. But the problem was the colectomy rates required to sustain this kind of mortality was up to 30%. So the focus eventually shifted from reducing the mortality, because now we had achieved a mortality of 1%. The focus was now shifted to avoiding colectomy. So avoiding colectomy with the use of specific agents and use of drugs which could have side effects which were lesser than steroids. So that is when this search for newer drugs started. If you see the long-term outcome with steroids, and there was a beautiful study published in 2001 in gastroenterology. 63 patients who were started on corticosteroids. Out of them, in 1 month, 54% achieved complete remission, 30% achieved partial remission, and 16% had no response or they were refractory to corticosteroids. When these set of patients were followed up for 1 year, prolonged response was seen in 49% of the patients. Steroid dependency was seen in 22% of the patients, and 29% of the patients underwent surgery. So it was this group of patients who required some additional treatment apart from steroids, because they were not responding in the way that they should have. There was another study based on 114 patients who had their complete remission on the first course of corticosteroids, and they were followed up for around 7 years. So they found out that the probability of further corticosteroid therapy as the time increased kept on increasing. So at 1 year, 10% of the patients again received steroids, again required steroids. At 3 years, 29% again required steroids. And at 5 years, 45% of the patients again had to be introduced on corticosteroids. And during this entire duration, 42% of the patients were either steroid dependent, and 17% of the patients were steroid refractory. So when we see the goals of treatment in ulcerative colitis, the present goals that we have is to achieve and maintain remission of disease activity. The maintenance of remission could be either clinical remission, it could be endoscopic remission, it could be histological remission, and one of the most important criteria used is the ability to achieve a steroid-free remission. So that is an important target. Now, when we talk of steroid refractory ulcerative colitis, as Dr. Anil had just mentioned, there are two categories of patients. One is a steroid resistant, or also sometimes called as refractory in a few studies. So these are the patients who do not respond to the initial steroids. What do you mean by initial steroids? The steroids which have been given at a dose of 0.75 to 1 milligram per kg, body weight of prednisolone equivalent for 4 weeks, or they have been given IV steroids, which could be IV hydrocortisone 100 milligrams 6 hourly, or IV methylprednisolone 60 milligrams per day for 1 week. So despite this dose of steroids, they have not responded. The other category of patients is steroid dependent UC. So these are the patients who have initially responded to steroids, but then they cannot be tapered off. So they cannot be tapered off to an equivalent of dose, which is equal to prednisolone 10 milligram per day within 3 months, or once they have stopped the steroids, they relapse within the next 3 months. So these are the two categories of patients when we talk of steroid refractory ulcerative colitis. So to discuss patients with ulcerative colitis who are not responding to steroids could either be acute severe ulcerative colitis patients who are refractory to IV steroids. They could be moderate ulcerative colitis patients who are usually on oral steroids and they are now refractory to these oral steroids. Or the third category could be steroid dependent ulcerative colitis. So in these three category of patients, which are the three drugs most commonly used, cyclosporin, infliximab, and adalimumab, which one and how they are to be used? So as Dr. Anil had briefly discussed, infliximab and adalimumab are anti-TNF and agents So infliximab is a chimeric agent which utilizes mouse as well as human antibodies against TNF alpha. It has a half-life of 9.5 days. Adalimumab is a fully human monoclonal antibody, and it acts, and both of these agents act against the free as well as bound TNF alpha, and hence it prevents the downstream activation of the inflammatory cascade. On the other hand, cyclosporin is an agent which inhibits an important enzyme called calcineurin, which is responsible for activation of several inflammatory markers, most important amongst which is interleukin 2. The half-life of cyclosporin is much less, it is around 8 to 24 hours. Because these agents would be used very commonly in clinical practice, I would just like to discuss in brief regarding the major aspects of these drugs. Infliximab, the route is intravenous. Adalimumab is given as a subcutaneous dose. Cyclosporin is initially given as an intravenous dose and then oral. The induction dose for infliximab is 5 milligrams per kg at 0, 2, and 6 weeks, followed by a maintenance of 5 milligram per kg every 8 weeks. Adalimumab is given at 160 milligrams subcutaneously at 0 weeks, then 80 milligrams at 2 weeks, followed by a maintenance of 40 milligrams every 2 weeks. For cyclosporin, it is started as a dose of 2 milligram per kg per day, up to some studies have used 4 milligram per kg per day to maintain essentially a trough level of 150 to 250 nanogram per ml. IV dose is used maximally for 7 days. In responders, you switch to oral, which is given at a dose of 4 milligram per kg per day. I'm giving all this information because most of this information could be used in deciding between the regimens that are used. The induction time for infliximab is around 7 days, for adalimumab around 14 days, and for cyclosporin is around 4 days. Several studies which have been published show the reactivation rates of tuberculosis with infliximab in India or the Southeast Asian region would be around 4 to 14%, with adalimumab slightly lesser at 3 to 10%. The Western studies give the reactivation rates to be much lesser at 1 to 3%. Not a significant reactivation rates with cyclosporin are seen. The pregnancy category for infliximab and adalimumab is category B, whereas for cyclosporin it is category C. A rough estimate would be an induction cost requirement for infliximab would be around 2,50,000 rupees, followed by a maintenance of around 50,000 per month. Adalimumab would be costing somewhere around 1,50,000 per for induction, followed by a maintenance of 45,000. And cyclosporin would be costing around 50,000 for induction and maintenance for not exactly maintenance, but the oral doses which are used for 3 months would be costing around 6,000 rupees. So this is a rough estimate. Before starting infliximab, what has to be seen? You have to screen for active or latent TB. The investigations used are chest X-ray, MANTO, or interferon gamma release assays. Viral markers, whether there is any evidence of sepsis or ongoing infection. Checking for heart failure is very important because in patients with NYHA 3 or 4 category of heart failure, it is completely contraindicated. In NYHA 1 and 2, it could be used with caution. It should not be used in people who had a previous hypersensitivity reaction to infliximab. Patients with seizure disorder, demyelinating disease, you have to be careful. Immunization history is one of the things which is most oftenly neglected by most of us. So adult immunization is an important topic before we start with biologicals, and that has to be looked into. The adverse events with infliximab, I have only mentioned those adverse events which have an incidence rate of more than 10%, includes the development of anti-nuclear antibodies, antibodies to dsDNA. Upper respiratory infection, respiratory tract infection is fairly common. Abdominal pain, infusion-related reactions, diarrhea, headache, and mild elevations of ALT. For adalimumab, again, screen for active or latent TB, check for viral markers, see for sepsis or ongoing infection, and see for immunization history. The adverse events, injection site pain is a very common feature. Upper respiratory tract infections are again common. Increased creatinine phosphokinase, headache, and rash are seen. For cyclosporin, 2 important things apart from infections that have to be seen. You have to be very sure of the blood cholesterol levels, because if the blood cholesterol levels are less than 115, it is contraindicated. The serum creatinine is also very important. You have to keep monitoring serum creatinine levels during ongoing cyclosporin therapy, because it has to be stopped if creatinine increases by more than 25% more than the baseline. Serum magnesium levels are very important. It is contraindicated if serum magnesium levels are less than 1.4 milliequivalent per liter. Also, monitoring the blood pressure is very important because there are several side effects seen with cyclosporin, essentially tremor, nephrotoxicity, hypertension, infection, hirsutism, female reproductive disorders, gum hyperplasia, increase in triglyceride levels, abdominal discomfort, leg cramps, or paresthesia. These are the most common adverse cyclosporin. So now coming to the first category, that is acute severe ulcerative colitis, which is to IV steroids. Which one should be used? Cyclosporin, infliximab, or adalimumab. So when we talk of acute severe ulcerative colitis, the most common definition of acute severe colitis used by ulcerative colitis used by most of the studies is that which has been traditionally based on the Truelove and Witts criteria, that is having 6 bloody stools per day along with any one of the systemic features, which could be tachycardia, fever, drop in a low hemoglobin of less than 10.5 or a high ESR of more than 30. So, as Dr. Anil had briefly discussed, the initial approach to acute severe ulcerative colitis is first we have a baseline investigation. Importantly, we should have a hemogram, creatinine, the electrolyte levels, an X-ray abdomen to rule out megacolon, sigmoidoscopy with biopsies to see for CMV and C. difficile toxin. Initially, you have to replenish with IV fluids, manage their electrolyte levels. A low molecular weight heparin is important, and treat infections with, if any. At day 3, you have to assess the response. Some studies have also taken it for later days using different criteria, but Oxford criteria is one of the most common criteria used, where you categorize the patients based on the stool frequency and the CRP levels. So if you have a stool frequency of less than 3 per day, it is a complete response. If you have a stool frequency which is 3 to 8 per day, but a CRP level which is lesser than 45, it is partial response, and no response when the stool frequency is also very high, or you have a stool frequency which is 3 to 8 per day, but you also have a high CRP. Now, Oxford criteria is a robust criteria because it was seen that patients who were categorized according to the Oxford criteria and were followed up for 10 years, in patients who were complete responders, the colectomy rate was 5%. For patients who had incomplete response, the colectomy rate at 1% was 54%. And the maximum steroid-free remission for the complete responders was 3.5 years versus only less than 1 year in patients who had an incomplete response. So Oxford criteria is an excellent way to categorize these patients. So once you have complete response, you can very well continue these patients and taper them on oral steroids and add azathioprine when the steroid levels go down to less than 20 milligram per day. But for patients who have partial response or who have no response, you have to do something else. So you either have a medical rescue therapy, which could be in the form of infliximab, adalimumab, cyclosporin, which I shall now discuss, or you can go in for a colectomy. So first, coming to cyclosporin. Cyclosporin, the first landmark trial, which was published in 1994, and it was very interesting. It was published in NEJM. So this trial involved only 20 patients with steroid refractory acute severe ulcerative colitis. 11 received cyclosporin. The dose initially used was higher. It was 4 milligram per kg per day, and 9 received placebo. 9 out of the 11 patients in the cyclosporin group had a response, whereas none in the placebo group had any response. The 5 patients from the placebo treatment group were crossed over to the cyclosporin and all responded. So the trial was terminated early for ethical reasons because obviously cyclosporin was an excellent drug for ASUC. Subsequently, in 2003, a randomized trial was published where they found, the differential dosing was used. For patients with 4 milligram per kg per day or 2 milligram per kg per day, the response rate at 8 days and the colectomy rates were similar. So eventually, the 2 milligram per kg per day dose has now become standard because you would like to reduce the dose of cyclosporin considering the side effects. The long-term response rates for patients with acute severe ulcerative colitis with cyclosporin, the initial response is excellent. 74% response is good. But if you see, as the time progresses, at 1 year, 65% relapsed. At 3 years, 90% of the patients relapsed. And at 7 years, 58% of the patients underwent colectomy, so which is quite a high number. So another study, which studied the colectomy rates at around 5 to 6 years, found out that when cyclosporin was given alone, the colectomy rates were 60%, But when cyclosporin was added on along azathioprine or an immunomodulator like azathioprine or 6-MP was used, the colectomy rates came down to 33%. So adding an immunomodulator was obviously beneficial. But the paradox is, in patients when cyclosporin was used in patients who were already exposed to azathioprine. So in patients who were de novo, who were not exposed to azathioprine, the colectomy rates were lesser as compared to no colectomy. But patients who were already in azathioprine, the colectomy rates were higher as compared to patients who did not undergo colectomy. So in ASUC patients already on immunomodulators, the likelihood of needing a colectomy following treatment with cyclosporin is higher than among those in whom immunomodulators are started later, that is after the cyclosporin has been started. So this is an important point. The most important concern with cyclosporin is that side effects are pretty common. Minor side effects are seen in around 30 to 50% of the patients, even in the short term. So cyclosporin should be used preferentially as a bridge to immunomodulators, which can then be used as a maintenance therapy to reduce the exposure to cyclosporin as much as possible. So how cyclosporin is given? You give 2 milligram per kg per day at the beginning when cyclosporin is used. You see for response at day 7. In patients who respond, you switch to oral cyclosporin at a dose of around 4 milligram per kg per day. Keep seeing the trough levels. It should be maintained between 150 to 250 milligram mg per ml. And you also add azathioprine. At 3 months, you stop cyclosporin and continue the patient only on azathioprine. For patients who do not respond, you could either go for colectomy or any alternative RX, which we shall discuss later. Now coming on to infliximab. Infliximab in steroid refractory ulcerative colitis, the first open label study was published in 2001, where they studied the role of infliximab in 6 patients with steroid refractory ASUC. And they found out that a single infusion at 5 milligram per kg showed marked improvement in all patients. And 4 out of the 6 patients were in long-term remission at a median follow-up of even 5 to 6 months. In 2005, there was a randomized control trial used of infliximab, and they found out that the colectomy rates in patients who had received infliximab were much lower as compared to patients who had received the placebo. One important thing that they also noticed was the maximum benefit of infliximab was seen in patients with moderately severe disease than those with the most severe disease. So patients who had relatively moderately severe disease had better responses as compared to the more severe category of ulcerative colitis patients. Also, in contrast to cyclosporin, the prior exposure to thiopurines did not affect the outcome of patients treated with infliximab. So the prior exposure to immunomodulators does not matter. The long-term follow-up if you see, of infliximab in patients with steroid refractory ulcerative colitis, at 1 year, the colectomy rates were 25%, which is quite less as compared to cyclosporin. At 5 years, it is also 39%. So if you compare the colectomy rates with cyclosporin, the initial colectomy rates might be similar, but as time progresses, as patients are maintained for a longer period of time, the colectomy rates with infliximab are much lower as compared to those patients on cyclosporin. So this is a definite advantage. So what is the current scenario with the use of infliximab? With the use of infliximab, we are now seeing that the mortality rates have remained the same, but the colectomy rates have been gradually declining with time, and more and more studies are available, which give us long-term follow-up of these patients, the colectomy rates are lower as compared to other agents. There are certain caveats, however, when you use infliximab. There are certain factors which might negatively affect outcomes with infliximab. Studies have shown that an increased baseline CRP of more than 20, high CRP to albumin ratio, that is high CRP, lower albumin, you have a poorer response. If you have a high baseline Mayo score, that is higher inflammatory activity at baseline, the outcomes might be negative. So what is the reason for this? So if you have a high inflammatory load, it also means that a higher load would be required to neutralize the excessive TNF alpha that might be present in the circulation. These patients usually have lower serum albumin levels and also an inflamed colon. which allows easy efflux of the infliximab in the colonic lumen and hence the fecal loss of the drug. Increased fecal loss, increased clearance causes low drug concentrations to act, and because the lower drug concentrations are present, the anti-drug antibodies increase, and thus immunogenicity against infliximab increases. So, based on this scenario, there have been studies which have tried to use accelerated infliximab in steroid refractory ulcerative colitis. In 2015, Gibson et al. Reported that he used an accelerated regimen of infliximab, where he used 3 doses of infliximab over a period of 2 weeks. And he reported that at 3 months, the colectomy rates were 40% in the conventional dosing group, but it was only 6.7% in the accelerated regimen, so it was clearly less. However, later on, a meta-analysis which has been published, they have reported that the outcomes are not better with an accelerated infliximab regimen. There is an ongoing comparative RCT, head-to-head RCT with different infliximab induction regimens for acute severe ulcerative colitis, and we should have clearer answers after we get the results of this trial. Also, it is important to understand that the action of infliximab or the results with infliximab or any other anti-TNF agent also depends on the body weight of the patients. So this is a recently published in 2020. This was published. This is a meta-analysis which has observed that the obesity increases the odds of failure of anti-TNF therapy, and this is especially so in patients with ulcerative colitis. So they have said that obese ulcerative colitis patients might require higher doses in the anti-TNF treatment. So now we have discussed regarding cyclosporin and infliximab. So are there any head-to-head trials which have compared cyclosporin versus infliximab directly in ESUC? Yes. The CYSIF trial, it was a RCT which used thiopurine naive patients, and they used 5 days of IV, and these patients were steroid refractory. They found out that the response to treatment at day 7 were 85% in both the groups, that is both in cyclosporin as well as infliximab. The treatment failure and colectomy rates at around 3 months were also similar between both the groups. That is, early colectomy rates were also similar between both the groups. And so none of these agents were superior to each other for early outcomes. Now, if an agent does not work, can we switch between infliximab and cyclosporin? So the study was published in 2009. Where 86 acute severe ulcerative colitis patients with failure to rescue therapy with either infliximab or cyclosporin. So 65 patients were administered infliximab after cyclosporin failed, and 21 patients had cyclosporin after infliximab failed. The problem was there were several adverse events. 33% of the patients underwent colectomy within 3 months, and 1/3 of the patients of the entire cohort had adverse events in the form of infections. So this switching over is not recommended now. To the best of my knowledge, adalimumab for acute severe ulcerative colitis, there is no published trial yet. The utility might be questionable because adalimumab has a longer onset of action as compared to infliximab, and you have a fixed non-weight based regimen. You have a fixed dose of adalimumab, which might not work in these severely inflamed patients. So just to summarize, this was a beautiful chart published in one of the papers by Dr. Vinny. Summary for steroid refractory ulcerative colitis: how do you decide between cyclosporin and infliximab? See for comorbidities, whether the patient is azathioprine exposed or azathioprine naive. See the inflammatory load. More severe disease, you might prefer cyclosporin over infliximab. In obese patients, again, infliximab might have lesser outcomes. And patient preferences are also important, considering the cost, considering the side effect profile. So cyclosporin, either cyclosporin used or infliximab used, you see the response at day 4 or day 4 to day 7. In cyclosporin, if you have an adequate response at day 7, switch to oral cyclosporin. And as I said, maintain on azathioprine after 30 days. With infliximab, if you have adequate dose, you can continue infliximab maintenance and add azathioprine as a maintenance. So now coming to the next category of patients, that is moderately severe ulcerative colitis who are refractory usually to oral corticosteroids, and steroid dependent ulcerative colitis. Now, which agent should be used? In cyclosporine, infliximab, or adalimumab? So to categorize between these two categories of patients, that is oral steroid refractory or steroid dependent, is not available in most of the studies, because most of the studies have taken both these classes of patients, and very rarely a distinction is made. However, there was one study which focused exclusively on steroid dependent ulcerative colitis. They found out the role of infliximab in these patients, and they found out in there 126 patients were enrolled, and they found out that the 6-month, 12-month corticosteroid free remission rates were 53% and 46% with infliximab. The colectomy free survival rate was also much better with infliximab in the infliximab group as compared to the patients who were only on steroids. Two other observations that they made: when these patients were followed up for 6 months to 12 months, patients who were infliximab plus azathioprine fared much better with lower probability of remission as compared to patients who were on infliximab monotherapy alone. And patients who had achieved normal CRP after induction therapy with infliximab had a lesser probability of remission as compared to patients who had a high CRP even after the induction dose. So again, focusing on the inflammatory load. Two important trials, the most often quoted trials, that is the ACT-1 and the ACT-2 trials. In these two randomized controlled trials, there were 364 patients who had confirmed moderate to severe ulcerative colitis, out of which 204 patients were either steroid refractory or dependent. You can see that the infliximab rates, the response to infliximab, that is the clinical response at week 8, the clinical remission at week 8, the corticosteroid free remission at week 30, and the corticosteroid free remission at 1 year is much better in infliximab as compared to placebo in both these trials. The use of adalimumab, the ultra trials are the most popular and most often quoted randomized controlled trials. I have chosen Ultra 2 trial because they had the clear distinction of patients who are steroid refractory or dependent. In the Ultra 2 trial, the 494 patients with confirmed moderate to severe ulcerative colitis were taken. Out of that, 292 patients were either steroid refractory or steroid dependent, and the response rates with adalimumab at week 8, both response and remission, at week 16, and corticosteroid free remission at 1 year were significantly higher in the adalimumab group as compared to placebo. Now, if you compare infliximab with adalimumab, if you compare the results of these two trials, people have tried comparing the results by matching the several confounders, and you could reach to a conclusion that infliximab has better response rates as compared to placebo in both these trials as compared to adalimumab. So the response rates at week 8 or the corticosteroid free remission rates at 1 year seem to be better with infliximab or adalimumab, but this comparison might not be justified because both were separate cohort of patients with different characteristics. So are there any head-to-head trials which have been done between infliximab and adalimumab? A recent trial which was published in Medicine did a head-to-head trial between infliximab and adalimumab, and they found out that the overall response rates at week 14 were almost equal between both infliximab and adalimumab in terms of both clinical response rates, steroid-free remission rates, and mucosal healing. And the responses also at 1 year, that is a clinical response, the overall remission, steroid-free remission, mucosal healing, were both equivalent in both these infliximab as well as adalimumab. So there is not much to choose between these patients. Another article just published recently in Nature. So this also tried to match tried to see the differences between infliximab and adalimumab, and they found out that the clinical response to infliximab and adalimumab is almost equivalent at 8 weeks. The remission rates are also not significantly different. The long-term relapse-free survival between infliximab and adalimumab is also not significantly different between the two groups, but as time progresses, maybe there is a slighter advantage to adalimumab as compared to infliximab. However, this difference quoted was insignificant. So, studies which have been published which show the combination therapy, whether when you use immunomodulators along with the infliximab or adalimumab, there is a UC success trial in which steroid-free remission was achieved in 39, around 40% of the patients who received a combination of infliximab and azathioprine compared to infliximab alone. So they were better when used in combination. For adalimumab, there is a RCT which has been published for Crohn's disease. In ulcerative colitis, it is possibly still not there. For Crohn's disease, there was a greater endoscopic remission in favor of combination Rex. So synopsis for steroid dependent or steroid refractory patients who are moderate on oral steroids. For oral steroid refractory or steroid dependent ulcerative colitis, both these agents might be equivalent to each other. So eventually, it all boils down to the patient's preferences. There is no clear advantage of one agent over the other. Patient preferences in the terms of convenience or cost might play a predominant role in choosing between these two patients. So to conclude, effective medical rescue therapies are available for treatment of steroid refractory ulcerative colitis. For IV steroid refractory ulcerative colitis, infliximab and cyclosporine are equally effective as rescue therapy to reduce colectomy rates in the short-term follow-up. Mortality rates remain unchanged with the use of these drugs. The choice may be guided by underlying comorbidities, presence of obesity, prior immunomodulator exposure, higher disease burden, and the patient or physician preference. Infliximab is superior to cyclosporine at avoiding colectomy in the long-term follow-up. So infliximab has an advantage over that. For steroid dependent and steroid refractory moderately severe ulcerative colitis, infliximab and adalimumab have equal efficacy, and choice may be guided predominantly by patient or physician preference. Thank you very much.
Thank you, Dr. Srihari. We'll have questions later on, and may I invite Dr. Kochar to invite Dr. Vineet Ahuja, please.
Yes, yeah. So we had a very elaborate talk by Dr. Srihari, and now what is available beyond infliximab and adala is what Dr. Vineet Ahuja is going to tell us. And we have a molecule coming every few months, and this is something interesting, and probably will get a definitive treatment in not too distant future. So I'll request Dr. Vineet to talk about these two compounds, vedolizumab and tofacitinib, when and where to use in the context of steroid refractory or resistant ulcerative colitis. Dr. Vineet.
Thank you very much, sir. Thank you, sir, and good evening, everyone. So I'll be talking about these two new molecules, vedolizumab and tofacitinib. So I thought that as clinicians, there are 3 points which are very important to us whenever we want to use a drug. That is efficacy in a given situation, how good it is going to be, is it going to be safe, and cost is always a factor. No matter whether the patient is rich or poor, cost always remains a factor because these are drugs which have to be given for practically a very long duration of time. So just a few slides on how do these two drugs act. The reason for that is because that helps us to understand subsequently when we talk about the situations where they're going to act. When we talk about vedolizumab essentially is a lymphocyte trafficking inhibitor. You have lymphocytes in the bloodstream, and they have to go to the site of inflammation in the lamina propria. So as a result, they have receptors on the lymphocytes have receptors which are alpha-4 beta-7 integrin receptors, and there are receptors on the endothelium known as the MATCAM1 receptors. When there's interaction of these two receptors, the lymphocytes are able to go across the endothelial wall and reach the site of inflammation and cause inflammation. However, if you block these receptors with the help of vedolizumab, which is an alpha-4 beta-7 inhibitor, the lymphocytes are not able to reach to the lamina propria. Now, vedolizumab has a long half-life. It has a half-life of roughly around 25 days. Infliximab has a half-life of around 7 to 10 days. Secondly, vedolizumab acts on alpha 4 beta 7, which are gut receptors. So it has a gut homing action. It has a long half-life, it has a slow onset of action, but it maintains the action very well. And at the same time, if you are planning surgery, remember that this long half-life means that there will be a longer weaning of time which will be required. Now, vedolizumab targets only one main side receptor, that is alpha 4 beta 7, whereas when we talk about tofacitinib, it has mechanistically, it has two advantages. One is that it can target multiple cytokines. Secondly, it is an oral small molecule in terms that it can be given orally. None of the currently approved biological therapies, they target the intracellular component of cytokine signaling pathway. The very important cytokine signaling pathway is the Janus kinase pathway. Any cytokine, if it has to act, when it comes onto any cell, it has to attach to receptors, and these are the Janus kinase pathway gets activated, which leads on to dimerization of the STAT pathway, which moves on inside the nucleus and activates all the pro-inflammatory or the anti-inflammatory. Both of them can be activated. So we have JAK1, JAK2, JAK3, and TY tyrosine kinase 2 receptor. And the good part out here is that if you block, let's say, JAK1 or JAK3, you're not blocking one cytokine, you're blocking multiple cytokines, as you can see, IL-2, 7, 15, 21, 6. So that way, the tofacitinib, it is an oral small molecule. It blocks the JAK inhibitors, JAK receptors. As a result, STAT cascade activation is blocked and the inflammation does not occur. So tofacitinib, it is orally administered. It is not a monoclonal antibody. So as a result, there'll be no immunogenicity or antibody formation. It is easy to make. There'll be low production cost. Half-life is only 3 hours. So it has a very, very fast action. That is what you have to keep in mind. Now let's talk about the three pillars which we thought about: efficacy, safety, and cost for vedolizumab and tofacitinib. I'm not going to put too much data across. Trust me, when I say yes or no, that means the trials are available which say that, okay, there has been statistically significant effect in terms of efficacy. So when we talk about vedolizumab and ulcerative colitis, we have conditions where you would like to, situations in ulcerative colitis where you would like to use any biological agent would be steroid dependent, steroid refractory ulcerative colitis. There vedolizumab works. In acute severe ulcerative colitis, would vedolizumab act? As I told you, it has a long half-life, it has a slow onset of action. So vedolizumab does not act well in a case of acute severe ulcerative colitis where you want instant action, where you want immediate something to happen. No, it does not help. Surprisingly and strangely, people thought that patients with ulcerative colitis, with primary sclerosing cholangitis, or with extraintestinal manifestations, vedolizumab would be very useful. But data shows clearly that it does not help in extraintestinal manifestations, probably because it just has a gut homing action. In fact, some of the patients with arthralgias worsened when they were given vedolizumab, patients who had arthralgias along with ulcerative colitis. So this is the status of, so it's very important to remember that which subsets of ulcerative colitis vedolizumab would be useful. What about Crohn's disease? Again, Crohn's disease is a heterogeneous disease. The moment we read studies, okay, vedolizumab is useful in Crohn's disease, does not mean the data is available for all kinds of subsets of Crohn's disease. The data is available mainly for inflammatory Crohn's disease. Even in inflammatory Crohn's disease, if it's a severe disease where you require immediate action, vedolizumab will not act very well. For stricturing disease, Crohn's disease, data is still emerging. For fistulizing Crohn's disease, data is still emerging. For perianal fistula, Crohn's disease, vedolizumab data is still emerging. Extraintestinal manifestations, as I told you, ulcerative colitis or Crohn's disease, vedolizumab is not effective. Post-op recurrence in Crohn's disease data is still emerging. So robust data is available for B1 inflammatory disease. Otherwise, for stricturing, fistulizing perianal, you want to use it as a second-line therapy, you can use, but extensive data is still not available in terms of whether it is going to be really good or not. So if I combine both of them together, for vedolizumab, In ulcerative colitis, there's one main indication, steroid-dependent steroid refractory ulcerative colitis, where there are no extraintestinal manifestations and where there's no very severe acute component. For Crohn's disease, it is being used in B2 and B3, but that is being more used in real-life situations because there was no choice. Otherwise, data is available for B1 inflammatory disease. What about tofacitinib? Tofacitinib in ulcerative colitis, we find that it is useful in patients with steroid-dependent refractory ulcerative colitis. Yes, acute severe ulcerative colitis, in fact, data is emerging that it would be useful because it has such a fast onset of action within 3 hours. It has blocks multiple cytokines, so it would be useful. With extraintestinal manifestations also, it is useful because obviously it is a pan blocker. It is like something like steroid. It is a refined version of steroid, so it will block multiple cytokines. So it is useful in all the three situations. Surprisingly, tofacitinib was not found to be useful in Crohn's disease. So do not use tofacitinib in Crohn's disease, however much we may find it to be useful in ulcerative colitis. The next generation, or I would say the JAK1 selective JAK inhibitor, filgotinib, may have much value in Crohn's disease, but as of now, tofacitinib does not have value in Crohn's disease. So if I look at ulcerative colitis only, I find that vedolizumab, yes, useful, but in a subset of patients of ulcerative colitis. Whereas when I talk about tofacitinib, it is useful in practically all subsets of patients with ulcerative colitis. This is what I would like to keep in mind at the moment. Crohn's disease, vedolizumab is useful in B1 inflammatory disease. That is a place where maximum data is available, whereas tofacitinib is not useful in for Crohn's disease at all. So coming to two scenarios now in ulcerative colitis, that where would you like to use them? In patients who are steroid dependent, would you like to use them as first line therapy? When I say as first line therapy is instead of infliximab or adalimumab, which we use currently. And in patients with TNF failure, which one of them, vedolizumab or tofacitinib, would you like to use as second line therapy? Vedolizumab had a head-to-head trial, a very famous trial, VARSITY trial, which came up last year, versus adalimumab for patients with moderate to severe ulcerative colitis, which showed that vedolizumab was superior to adalimumab, right? But at the same time, the success rate was not so good when it came to patients who had previous TNF inhibitor therapy. There it was not found to be, it was found to be, the delta was not so good, the differences were not so good out here. Whereas when we look at the OCTAVE trial of tofacitinib in patients with ulcerative colitis, I want you to just look at patients who had prior TNF inhibitors. This is the induction, the clinical remission induction, and this is the maintenance therapy. What we find is that even in patients who had prior TNF inhibitor therapy, the success rates were quite good, and it seems to be useful. Now, the interesting part is that when we look at network meta-analysis, that is what could be the best first and line, second line pharmacotherapies which could be available for ulcerative colitis, we find that in biological naive patients, infliximab is probably the best because it was ranked highest for induction of clinical as well as endoscopic improvement. And the trial which was done was not done for vedolizumab versus infliximab. It was done for vedolizumab versus adalimumab. And we already know that infliximab is superior to adalimumab when it comes to ulcerative colitis in biological naive patients. So keep that in mind. Second thing is that in patients with prior exposure to TNF antagonists, ustekinumab and tofacitinib were superior to vedolizumab and adalimumab. Clearly, vedolizumab scores in terms of safety. The lowest risk of infection was seen with vedolizumab, followed by ustekinumab. So this is a network and meta-analysis which has come up just 2-3 months back, clearly showing that in biological naive patients, infliximab still is the trusted drug. In patients who had prior exposure to TNF antagonists, since ustekinumab is not available in our country right now, tofacitinib would be superior to vedolizumab. In patients, particularly elderly, those who have history of malignancy, somebody with, or those who have a high risk of infection, you would like to think about vedolizumab in that setting. So in infliximab failure, or as a when a patient has been on steroids, subsequently given infliximab, and there you have to decide whether you would like to put the patient on vedolizumab or tofacitinib. I would say that one tofacitinib appears to be superior to vedolizumab, except that vedolizumab can be the first or second line therapy for ulcerative colitis in patients who are elderly, 70 years or above, where there is risk of, or where there is risk of infection is high, or intolerance or contraindication of to TNF blockers like congestive cardiac failure, or previous history of solid organ malignancy. So now let's come to safety. Safety, as we discussed, that when it comes to vedolizumab, it appears to be a safer drug as compared to tofacitinib. So what about tofacitinib? So a few slides on not only the safety of tofacitinib, but how are you going to start it, how are you going to initiate it, how are you going to screen a patient. That is, I think, I felt it was important, so I'll be touching upon it. Screening before tofacitinib is same as screening for any patient when you start the patient on biologics. You have to look for latent active TB. You have to look for history of herpes zoster and chickenpox. That is important, particularly for tofacitinib. And you have to look for risk factors for venous thromboembolic disease. Besides that, the normal hemoglobin levels and lymphocyte counts and ALT, AST need to be done. Tofacitinib is contraindicated in all patients, pregnancy as well as lactation. Contraception should be advised for women of childbearing potential if they go on tofacitinib, and it should be maintained till 4 weeks after the last tofacitinib administration. For vedolizumab, again, the data for pregnancy is emerging. It is still sketchy data. We still think it is safe, but we are not very sure that it is safe. But for tofacitinib, it is very clear not to be given in pregnancy. How to give tofacitinib? There's an induction phase, maintenance phase. Induction phase is 10 milligrams BD given for 8 weeks. If the patient shows benefit, then generally you decrease the dose and give it 5 milligrams BD subsequently for as long as you have to give. So 10 milligrams twice a day for 8 weeks, and thereafter 5 milligrams twice a day thereafter. Remember that the drug metabolism is affected by cytochrome, CYP2C19, etc. So CYP3A inhibitors like ketoconazole or fluconazole and all, there you have to reduce the dose of tofacitinib. Rifampicin is a CYP inducer, so it may decrease the efficacy of tofacitinib. Do not combine tofacitinib with cyclosporin or tacrolimus. In patients with hepatic and renal impairment, decrease the dose up to 50% if there is moderate renal failure or moderate hepatic failure. When you started a patient on tofacitinib, you need to check for the CBC initially. Subsequently, after 4 to 8 weeks, not only you check for the complete blood counts, you also check for lipids. And besides that, you're monitoring for two important things. One is infection in the form of herpes zoster. Second is venous thromboembolism, because it seems to predispose to venous thromboembolism. In fact, the major side effects for the serious side effects which one has to look for in tofacitinib is venous thromboembolism or thromboembolic events. And second side effect which one has to look for is herpes zoster or activation of herpes zoster infection. Besides that, there may be cytopenias or increase in the lipid level derangement. So the main side effect, as I said, told you, was to look for is herpes zoster reactivation. However, the important thing to remember out here is that it generally occurs with higher doses, 10 milligram BD. With 5 milligram BD, the chances of acquiring herpes zoster infection are less. There is a risk for DVT, deep vein thrombosis or pulmonary thromboembolism, but it is not very high. Again, this is dose dependent and occurs when the patient is on induction therapy, that is 10 milligram BD. So if you're planning to put on tofacitinib and there is time to plan therapy, then it is better to give herpes zoster vaccine, particularly in anybody who's over 50 years of age. In India, only live attenuated vaccine is available, Zostavax. Subcutaneous 8 to 10,000 rupees, to be given 1 to 2 months before initiation, since it's a live vaccine. The recombinant vaccine is not available. Then is that in patients, you have lipid profile changes, but remember they are responsive to statin therapy. That is something one would not be too much worried about. In fact, if you look at real life experience of tofacitinib and UC, we find that patients and venous thromboembolism occurred in, just like it did not occur in fact in this series also. Both these side effects are actually related to 10 milligram BD dose. Tofacitinib, as I told you, has a short half-life, 3 hours. Action within 3 days. Post-operative complications are less. May be useful as a second-line therapy, in fact, in acute severe ulcerative colitis. It not only reduces symptoms within 3 days, it has been seen that case series are emerging where people have used in acute severe ulcerative colitis patients, and the dose used is a little bit high in the sense that people have used up to 30 milligrams a day for 3 days, and they have found that it has been beneficial in patients who had failed to infliximab therapy. So that is it. So if I were to combine all of them, I would say tofacitinib offers advantages in terms of over vedolizumab, in terms of that you can, patients with extraintestinal manifestations, with concurrent inflammatory diseases, you would like to give tofacitinib. It's an oral drug, so easy to use, short half-life, no immunogenicity, and most importantly, clinical response is independent of previous TNF exposure. On the flip side is there is a risk for thromboembolism, there's a risk of herpes zoster, and there's a risk for infection, and it should not be given in pregnancy. So efficacy, safety, we have covered both of them. Finally, obviously cost, because I feel cost is, in fact, sometimes you would say, okay, cost is just 10-20% of it, of magnitude in terms of taking a decision. I would say, at least in our setting, in a government hospital setting, it would be more than 50% in terms of making a decision. So what are the cost differences? Vedolizumab comes with a brand name Kintelis. Takeda costs 70,000 rupees for 300 milligram vial. Induction dosing 0, 2, and 6 months, no, weeks. Sorry for the mistake, 0, 2, and 6 weeks. Maintenance dose every 8 weeks. So the cost would roughly range somewhere between 5.2 to 5.7 lakhs a year. Besides that, cover for the hospitalization cost also for infusion each time. Each time the patient would have to be admitted for a few hours for infusion. Subcutaneous vedolizumab is still not available in our country. Tofacitinib came up last month or 1 or 2 months back. These are many companies are making it. I think it has essentially come out mainly for patients with rheumatoid arthritis and dermatological conditions. So the cost out here, look at the difference in the cost. Look how economical this drug is in India. In Western countries, it's still very, very expensive. So if you look at the cost for tofacitinib in India, it is less than 5 ASA. It is less than the cost of mesalamine in India, or equivalent to the cost of mesalamine in India. So in fact, if you give it for 1 full year, one would be spending only 35 to 40,000 rupees. So if I put it all on a chart, ulcerative colitis, vedolizumab or tofacitinib, I find that the indications tofacitinib covers are much more than what vedolizumab covers. In terms of it, not only looks at steroid-dependent refractory, it also looks at ulcerative colitis with extraintestinal manifestations. It probably can be tried out in acute severe ulcerative colitis. Case series are emerging, and it is obviously a better drug than vedolizumab as a second-line therapy after infliximab failure. The niche area where vedolizumab would be, safety profile is better. So elderly, history of malignancy or CCF, there you would like to think about it. Ease of administration, I don't think there is any debate out there, because oral tablet is much easier for the patients than thinking of procuring an injection and walking all the way to the hospital and getting it injected. Cost, again, the figures speak for themselves. There's a huge difference out here. Crohn's disease. Now, the Crohn's disease, clearly, just to remind you that tofacitinib is not effective. So there vedolizumab, but again, the data is there for B1 inflammatory. It is not that vedolizumab should be the second line therapy blindfolded in all cases of Crohn's disease. No, most of the data is for B1 inflammatory. Rest of the data is still emerging. And finally, I would say I put up a provocative slide because something specific for India. This is what happened to hepatitis C virus in India when sofosbuvir, which was so expensive in Western countries, and it came out in a generic form in India and actually transformed the whole situation out there. So why we talk about tofacitinib as compared to vedolizumab? Why don't we talk about today? Why can't we think about tofacitinib as a clearly first-line therapy after steroids have failed, as a substitute for infliximab? Compare infliximab and tofacitinib. They have similar efficacy. They have a similar adverse event profile. Ease of administration is better for tofacitinib as compared to infliximab. And obviously, tofacitinib is highly economical as compared to infliximab. So this is some food for thought that I'll leave you with. Thank you so much for your attention, please.
Thank you, Vineet. Thank you all three for wonderful lectures and a lot of information packed into a very short time. Can we have the questions and answers? I think there are some questions over here. I'll read them out. Dr. Jaina asks, is there any role of directly acting oral anticoagulants in management of ulcerative colitis?
Is there any role of anticoagulants?
Oral
anticoagulants.
direct acting,
Yes,
DOACs.
Yeah, only when whenever 1 to 2% of patients have a thromboembolic disorder, so there you have to give or a direct, you can give direct oral acting anticoagulants. Besides that, when acute severe ulcerative colitis, there you do not give DOAC, there you would just give prophylactic heparin. When the patients are taken up for surgery, that is the single most important factor when patients will develop a thromboembolic disorder after surgery or within 3 months after surgery. So there you have to anticoagulate, whether you give warfarin in that setting or you can give a DOAC. But otherwise, in patients who develop pulmonary thromboembolism or thromboembolic disorder as an extraintestinal manifestation, which occurs in 1 to 2%, their DOAC is needed.
Will you use heparin or use Clexane?
So we generally, when it comes to patients who are of acute severe ulcerative colitis, we use Clexane unless until the patient is having severe bleed, then you can give heparin.
Okay. Second question is from Dr. Deepak. Is it of any advantage in adding AZA to when you start anti-TNF therapy?
I should answer. So AZA is been useful in patients with infliximab. There you can give for 6 months to 1 year, but stop it after 6 months to 1 year and continue just with infliximab. Adalimumab, most of the data suggests that it is not useful. Some data has come out which shows that okay, you may add, but in generally adalimumab it has not been found to be useful. Vedolizumab definitely not. Tofacitinib definitely not. So only in infliximab definitely yes. And again, not indefinite, that if patient is on infliximab for 3 years, you give the patient azathioprine also for 3 years. In fact, you stop azathioprine after 1 year or something and let the patient continue on infliximab.
There are many questions on consultation. I don't know how they got in this seminar. Vineet, why is that tofa is useful in ulcerative colitis and not in Crohn's?
So, because in the sense that if things were so simple, then we would have been taking care of corona also. Like, so, right now, also all you're doing is keeping him. So, tofacitinib is a JAK1, JAK2, JAK3, and tyrosine kinase inhibitor, whereas filgotinib is only a JAK1 inhibitor. So what happens is that when you have tofacitinib, so it blocks all the cytokines. So there are certain beneficial cytokines and there are certain harmful cytokines. In terms of that, it will also block IL-10. It blocks both type 1 and type 2 cytokines. So since it is going to block all the cytokines, so as a result, some of the beneficial cytokines will be getting blocked. So that could be the reason. Otherwise, it remains purely speculative. But filgotinib seems to be providing some advantage in the initial trials which have come up. So people feel that this is because of the selectivity of JAK1 receptor that it is providing the advantage.
No, my question was, why is it useful in ulcerative colitis and not in Crohn's?
So
what's the mechanism there?
So the mechanism remains the same, that it inhibits the cytokine signaling pathways. So it inhibits completely. But we do not know exactly what is the reason it is not useful in Crohn's. But again, a kind of drug which is like tofacitinib, that is filgotinib, which is a selective JAK1 inhibitor, that seems to be useful in Crohn's disease. So that could be one of the reasons.
And Vineet, what about use of tofacitinib in a patient who has already had herpes zoster?
Who has had herpes zoster? So
and here the vaccine may not work.
So I'm not very sure about it, sir, in the sense that whether the patient would develop antibodies or not. In terms of if a patient has had chicken pox, let's say, there the patient has an IgG antibody, there you can easily give infliximab, because in the sense that you don't need to vaccinate the patient, you know that the chicken pox should not get reactivated. Herpes zoster, I'm not very sure about it, but in the sense I don't think I'll be able to give a correct answer.
And Dr. Arora, again, you elaborated a lot on the mechanism of that. So main thing what I learned from you is that it's basically a genetic disease. So all three of you, do you think genetics entering into treatment of ulcerative colitis soon?
Problem is it does cause, you see, you may be predisposed to produce so many, MDR1 is one classical example in which there is an exacerbated response of efflux of the glucocorticoid, which may be responsible for lack of response to glucocorticoid. This is a genetic defect. And a lot of genes may get activated because of the continuing ongoing inflammation. And the basic relationship of the HLA, its response to the incoming antigen, and the balance between pro-inflammatory cytokines like IL-6, IL-12, IL-13, and IL-23 may be in total disarray as against anti-inflammatory cytokines like IL-10. So this all may be genetically mediated. Suppose you have more anti-inflammatory response, and even if there is a breach of the epithelial mucosa, it doesn't matter, because you see your anti-inflammatory component, as I showed you in my video, will take care of it. But if you are deficient on anti-inflammatory component, even a minor breach, like it's like triggering an irritable bowel syndrome, which occurs in patient with acute enteritis. 30% of the patient with IBS get triggered by one inflammation.
No, from your lecture, it was evident that only genetically predisposed people are going to get ulcerative
No, I
colitis.
said three things. I said you have it in a genetically predisposed individual.
Yes.
If there is either a chemical, biochemical, or microbiological.
So genetic predisposition is a must. So
Yes.
do you think any genetic therapy is going to take care of all these things?
Unless you are able to define it, you may not be. See, you may have gene editing tool, you may have CRISPR techniques coming on later on, but unless you're able to define it, because the interaction between the microbiome, the defensins produced by the epithelial mucosa, the type of reduction in the mucin 2, which is typical in ulcerative colitis, there is a multitude of complexity of interaction. To say that genetic abnormality will ultimately be the final component of treatment, it's not easy, because it is just an interplay of multiple factors.
Or we can say also add to that, sir, that in children pediatric very early onset IBD, there you have monogenic disorders. So once you pick up that only it's a single gene defect, a Mendelian disorder, so their bone marrow transplantation is being done. Somebody has
That's
an
very
iron
good.
deficiency, so there
That's
it has
very
been
good.
done. And so
Fantastic.
There are some questions from the participants.
Dr. Dadiji is asking, what's your experience with tofacitinib?
Sir, we just started using it last 1 or 2 months. Yesterday, we gave it to a patient with acute severe ulcerative colitis 2 days back. He seems to have responded after he had 2 episodes of acute severe ulcerative colitis. So this time we thought that he couldn't afford infliximab. So we started tofacitinib. Seems to be acting till now. Then otherwise, we started in few patients because it just came up like recently.
No, Vinit. Are you planning a randomized control trial?
We are planning a real world data collection right now and a randomized control trial in acute severe ulcerative colitis, where that will be a multi-center trial. So.
That will give you the answer, I think.
Yeah, can I ask a question to Vineet? Vineet, why not use tofacitinib as the first line therapy even ahead of, say, steroids in patients who are diabetic or hypertensive?
Problems.
I'm not very sure about that, in the sense that first we would like to first show that whether it is the first line therapy after steroids fail. Once you have that data, and then you can move on to above steroids, because the difference between using steroids is steroids you give for 3 months and stop, and then you put the patient on azathioprine and he may do well for years. Tofacitinib, once you start it, it's not necessary that you'll be able to stop it after 6 months. So then the adverse event profile may start building up. It would be like infliximab. You got my point.
Then
Steroid is episodic.
Anil, a known devil is better than an unknown devil. You know about steroid for 30, 40 years now.
And steroids are not giving more than 3 months or 4 months. Tofacitinib you'll be giving for a year when it is not required.
But if it is able to control the disease, you may switch on to azathioprine after that.
After tofacitinib,
suppose the patient is diabetic, hypertensive, why not start with tofacitinib to begin with, then switch on after 3 months?
So if a patient cannot take steroids, then in that case you can try it out. It's a good alternative which is available to us, definitely.
And Vineet, you continue with 5-ASA all the while.
If 5-ASA, generally what is happening is that if your patient is on long-term infliximab, then also 5-ASA is being stopped, because it was felt that 5-ASA is chemopreventive, so it should be continued. Earlier, that was a logic. But then the thing is that if you're decreasing inflammation, and inflammation is a driver for cancer, then maybe you can stop 5-ASA. So 2 papers appeared last year from Columbal's group in gut, one in gut and another in CGH, which showed that you can stop 5-ASA. So I think that if one is able to control inflammation, then you can stop 5-ASA, because the only advantage 5-ASA was giving was that it's chemopreventive. And that is a little bit debatable. So you can stop it.
Can I add to that, Dr. Vitti? Most of the guidelines still recommend low dose Misicol. If you remember, earlier we used to go up to 4.8 gram of Misicol. Current recommendations are up to 2.2 to 2.4 is good enough. You don't need to go to higher doses. That is one. Secondly, if you stop it without monitoring, you see, none of us in ulcerative colitis is looking for histological relief of the symptoms. Endoscopic relief or symptomatic relief is good enough. So if you do not monitor with, say, fecal chymotrypsin, and if you do not calprotect it, or if you do not monitor it with endoscopy, then low dose mesocol, most of us tend to continue.
Because it is because of the chemo preventive effect. But
Yeah.
that is where the gradually it is changing. So another 1 or 2 years, you'll find the same guidelines saying, okay, now you may stop 5 years.
Sir,
And
is
then you
there any-
continue the infliximab for how long?
Any number of years.
So every 8 weeks.
Every 8 weeks, as long as the patient does not have a loss of response, or the patient, in the sense that you have an exit strategy. Let's say after 2 years, the patient wants to stop infliximab for economical reasons, right? Then in that case, if it's complete healing, endoscopic healing, you can stop infliximab, but maintain the patient on azathioprine or something like that.
And then you
Otherwise,
can add 5-SA?
5-ASA you can stop if you want, but guidelines would say you continue. But at the same time, 5-ASA
No,
is
no. My question was, once you stop infliximab, can you add 5-ASA then?
no. Then you have to add azathioprine. If you add 5-ASA, the chance of relapse would be higher. Whenever you exit from one drug, then the next level drug should be added. So next level below infliximab would be azathioprine. That should be continued. That would have higher chances of maintaining the remission.
So would there be any role for therapeutic drug monitoring with the use of biologicals?
Oh, excellent. That's a lot of role.
Rough levels
It
have
has
to
to
be.
be because if you measure their drug levels, whenever the patient is doing well, you don't need to measure them. Only when the patient is not doing well, then you measure the drug levels. If the drug levels are high and the patient is not doing well, then it means that
Antibodies.
the drug is not acting. You don't even need to do the spend money on antibodies, because whether they are high or low, it will not change your decision.
Yes.
If the drug levels are low, then you check for the antibody levels also, whether the antibody levels are high or not. If the antibody levels are low, that means you increase the dose of drug, make it 5 milligram to 10 milligram per kg, or decrease the duration. Instead of every 8 weeks, now give 5 milligram per kg every 4 weeks, and the drug will start working. So that has
Any role of steroids or immunosuppressives in stopping the antibody formation in infliximab?
So infliximab generally, whenever it is given with pre-medication, hydrocortisone or even is given thoughtfully. To the concept behind that was that you decrease the immunogenicity, but subsequently shown that that is a practice carried many centers worldwide, but it has no use. You don't need to give that one. Number two, you need to add azathioprine to decrease the immunogenicity. That is why you add azathioprine for 6 months to adalimumab is a fully human monoclonal antibody, 100%. Still, it has antibodies, but azathioprine has not been shown to have so much of helpful role in terms of decreasing the antibody there. There are some nice questions in the chat box that are anticoagulants routinely required with tofacitinib. No, they are not routinely required with tofacitinib. In a UC patient with history of DVT, can one use TOFA? No, in a patient with history of deep vein thrombosis or predisposed to deep vein thrombosis, tofacitinib should not be used. Then there's one question: if patient is on adalimumab maintenance dose in UC and develops relapse, can we introduce tofacitinib as an additional agent? There the question is that you have two things to give. One is make adalimumab weekly instead of 2 weekly and see whether that way you get the response. Or if you don't want to do that, the patient is not able to afford that much of adalimumab, or that strategy does not work, then you stop adalimumab and give tofacitinib instead of giving both of them together in such a setting. Because dual therapy, dual biological plus small molecule therapy is used in very aggressive cases, because the chances of infection would be high. Then last question is interesting, that in the Indian scenario, can vedolizumab become a first line for steroid refractory ulcerative colitis? I think I've given the answer that tofacitinib may be a better choice because of the cost benefit it provides, considering the risk of TB reactivation with inflixia and TOFA. So we recently put in sending a paper, that's a DM thesis actually, that earlier TB reactivation was around 10% with infliximab. That is the data from India clearly. 10% cases में TB reactivation हो जाता है. But when we saw that a very strict screening strategy like IGRA, MONTU, CT chest is done. And on CT chest, even if you find old healed COX, calcified lymph node, then also you start the patient on INH. Or in other words, you have a very strict screening strategy and a low threshold for starting INH, then the risk of TB dropped down to practically 1%. Over last 60 cases, we have had only one case of TB. Prior to that, it was 10% risk of TB was there. So just with screening, good screening, because till now how we were screening is do either I want to do a IGRA, or even if you've done a CT chest, if it is active TB, then only you would not give infliximab. But here is that if you pick up even the calcified nodule out there, calcified lymph node out there, old TB, anything out there, or there's a previous history of TB in that patient, you start the patient on INH for 9 months along with that. It seems that this dramatic reduction in TB rates with just this simple strategy, it probably works.
That was my question to Dr. Srihari. Your algorithm said that you do a X-ray chest. I think a CT should be done instead of an X-ray chest.
Point well taken.
That may add to the cost.
But Dr. Vineet, but if you look at all things, calcified lymph node, MONTU, IGRA, chest X-ray, CT, I think 40% of the population will have one of these.
मतलब हमारे यहाँ 25% निकला था. आपकी बात ठीक है, high percentage है, but INH 9 months, if you give it to them, and if their reactivation of TB drops down to 1%, that is good enough.
So, Vineet, my question is, if you give it for 9 months INH, what are the chance of delay?
Sorry, sir, I couldn't understand the question.
If you're giving so many patients INH as prophylaxis, how many will have delay?
So for latent TB, people do take INH or INH plus rifampicin.
No. My question is, how many will have drug-induced liver injury?
Monotherapy will be very less.
No. Monotherapy also has. Even fulminant hepatic failure have been reported with that.
So monotherapy, just with INH, we did not find any single case. In fact, in the last 60 cases, as I'm talking,
and you're monitoring the ALT levels?
Yes, obviously.
Good. Very good. That's very heartening.
Yeah, Dr. Vineet, are we not increasing the chance of INH resistance with monotherapy in a country which has so much of rampant tuberculosis with monotherapy INH in say 30% of the population?
No, okay, but how many patients are you giving overall? No, think about it that way. Overall, in one center, you will be giving maximum 30 patients INH. Well, if you look at the overall number of infliximab, which in the country would be let's say 1,000 patients. Out of those 1,000 patients, 200 would be getting INH. So if you look at the dynamics of that, it's not that you are giving INH to communities or something that we are increasing the resistance rate.
And Anil, look at the other way around. If you're not giving INH, 20% chance and 1% chance over here. So you're decreasing florid tuberculosis, maybe MDR, XDR also.
So what do you only give monotherapy with INH, not with rifampicin?
We give INH. So you can give INH and rifampicin for 4 months or INH for 9 months. So we give INH.
We have a few questions. Dr. Karthikeyan has asked from, he's from Tamil Nadu. Once the patient showed response to monoclonal after 6 months, is it advisable to switch patient to mesalamine and azathioprine immunosine?
Yes, if the cost is an issue, you can think about it. But the only thing is that better to switch over after 1 or 2 years, and once you have shown endoscopic healing. If the patient, you do a endoscopy, show there's mucosal healing, then it will be better. You can also switch after 3 to 6 months. The Ludhiana data has shown that, Dr. Sood's data has shown that if you stop after 3 to 6 months and put the patient on azathioprine, then also the response comes. It does come. But again, the chance of relapse would be higher if you switch too soon.
Yeah, Dr. Jayanta is asking, ASUC is such a high prothrombotic state using TOFA as a second line.
But
is safety not concerned?
ASUC always prophylactically give heparin, you anticoagulate. So there's no harm in giving tofacitinib inhibitor.
I think.
Yes, sir.
I think we are running late. Everybody would be hungry. Maybe some people have had the pizza and.
You can give concluding remarks, sir.
Yes. Dr. Kochar, sir, first you.
I think Dr. Mishra, carry on.
I think we have a wonderful session and we had 3 very important topics. We learned a lot today, and especially from the personal experience too. And I think I thank Dr. Vineet, Dr. Anil, Dr. Srihari, and I think Dr. Arora, you wanted to say something?
Dr. Kochar first.
No, it was a wonderful session, and I think beneficial to everyone, and particularly knowing about what TOFA has, tofacitinib is, if available at this cost, is going to be a revolutionary thing.
It will be a game changer, I think.
Yes, exactly. As Vineet said, that like for hepatitis C, we may have something totally different for our patients. So that will be something great. Thank you.
Dr. Srihari, and
Srihari,
you can give.
In fact, it was more of a learning. It is always a pleasure to listen to Dr. Vineet and his immense knowledge. And the best part of being a part of this webinar is listening to him. So I'm really grateful to Professor Vineet Ahuja for his wonderful talk. Also, Dr.
He'll also say the same thing.
Yeah, and also Dr. Anil for his great talk. Thank you very much.
Thank you. I'm thankful to everybody from Daily Liver Foundation. First of all, it has given me a good opportunity to learn the basic gut immunology, and who else other than
Vineet is a master in that.
Certainly supplemented with what you see in day-to-day practice. I think it is a good combination of the basic science followed by what do we see on day-to-day basis. I think if you look at the slides of Vineet, he gives you a gist of what is known. I've been listening to his talk. After reading so much of the literature, he just summarizes. So you can easily find out that if vedolizumab, you will give it only in patients who have mild to moderate ulcerative colitis, and a clear-cut message that tofacitinib cannot be used in Crohn's disease. I think if you can go back with just 2 messages, that should be good enough.
And it will be a mainstay therapy then.
Yeah.
For ulcerative colitis.
And maybe we are switching over from, we are just getting it higher up in the ladder of usage in terms of its cost, in terms of its safety and easy availability, and the fact that it can be used it can be given orally. These are the advantages of it.
And I think it's a truly inspiring, like Dr. Arora's quest for knowledge and the way he goes back to basic science topics, and that too not only in every field, like hepatology ho gaya, functional bowel disease ho gaya, IBD ho gaya. He's taking up all the basic science topics and dissecting them very well. Like I couldn't hear today's talk. So I'm going to get the slides from him and have a look at it subsequently.
No, that is what we said, that even before he had started, that he's a multifaceted person, and this COVID has actually prompted him to go into all this.
Thanks to COVID.
Yes.
Dr. Mangesh, could you please sum up and wind up, please?
Right. Almost we had touched 200 participants, and many participants were really appreciating and asked about the YouTube link of
dropping very fast. They're going for dinner.
Yeah. So we are going to upload this video after editing, and it would be available and link would be shared. So I would like to thank you all participants, and on behalf of RPG Life Sciences, thank you to Delhi Liver Foundation for giving us this opportunity to host this program. So thank you so much to all participants.
Okay, thank you. Bye-bye, everybody.
Thank you.
Bye. Bye-bye.